want to thank Eric McCarty again for asking me to give this talk. Again, Adam Seidel, shoulder elbow surgeon at the University of Colorado. I'm here to talk about elbow tendon injuries, focusing on distal biceps and triceps injuries. Just a brief outline, again, talking about ruptures primarily of the distal biceps and triceps. I'll go briefly into the anatomy, how to diagnose these injuries, and then spend a little bit of time on the treatment of both distal biceps and triceps ruptures. Distal biceps anatomy. So as most of you know, there are two heads to the biceps, the long head and the short head. These come together distally and insert onto the radial tuberosity. The distal biceps rotates as it's inserting onto the radial tuberosity, rotates clockwise in the left elbow and counterclockwise in the right elbow. This is important to understand when repairing this. It attaches medially to the lacertus fibrosus, which is an important structure because when this is intact, it can actually fool you with a hook test or with a diagnosis of a distal biceps rupture, which I'll go into a little bit more detail in just a bit. Numerous cadaveric studies have looked at the role of the long and the short head of the biceps. Essentially, the short head of the biceps inserts more distally into the radial tuberosity. It acts more efficiently at elbow flexion, and it's more efficient at supination with elbow in pronation or neutral. The long head of the biceps inserts more proximally, and it's more efficient at supination with the elbow supinated, so resisted supination. The tendon inserts along the ulnar aspect of the radial tuberosity, as you can see here. It fans out as it inserts. So epidemiology, incidence of rupture, it's actually pretty rare, although most of us in the sports division see these injuries on a regular basis. So 2.6 per 100,000 patient years. The mean age is 46 years. 95% of these are male. I can say that I've never seen a female with a distal biceps rupture. Smoking, patients that smoke have an increased likelihood of injury, and then patients with an elevated BMI have an increased likelihood of a distal biceps rupture. Mechanism is typically a traumatic event of elbow flexion against resistance. Most patients come in and describe the injury with an audible pop, feeling like a gunshot to the elbow. Causes of this, so obviously there's the traumatic event, but this is also an area of hypovascularity, and you can have impingement, which is secondary to decreased radial ulnar space with pronation, as can be seen here. Physical exam, this is typically a pretty easy clinical diagnosis, so patients will present with tenderness and bruising in the antecubital fossa and along the medial forearm. They have pain with resisted biceps flexion and forearm supination, and then a hook test. A hook test should be performed from laterally, and the reason for that is if you have an intact lacertus and you perform a hook test from medially, you can be fooled into thinking that the distal biceps is actually intact. So the key here is coming lateral when you perform that hook test. Imaging, clinical exam typically confirms this diagnosis. I always get an MRI before I take these patients to surgery, although some surgeons do not. I think it helps, obviously, to evaluate for a full thickness versus a partial tear. And then it also helps you evaluate for the level of the tear and the retraction. I think the biggest thing for me is evaluating the level of the tear, as these can be musculotendinous tears. That's quite rare, but it's something you need to be prepared for when going to the operating room. So I tend to get an MRI beforehand. Management, distal biceps ruptures are typically treated with surgery. Recovery is about 4 to 6 months. Re-tear rate is pretty low, less than 2%. Non-operative management, you get patients that will ask about treating these without surgery, and studies have shown that patients experience 30% loss of flexion strength, 40% loss of supination power, and a loss of endurance. Actually, the thing that bothers the patients most is their loss of supination and their loss of endurance. Most patients can actually tolerate the loss of flexion. So surgical indications, again, almost everyone gets repaired. When I see them with a distal biceps rupture, really it's patients that are medically unfit for surgery that don't have this surgery. So who doesn't need a surgery? There's been several studies that look at this. This is a study looking at 18 patients that were managed non-operatively. And what they found is that patients overall were satisfied with their outcomes. But when looking at strength, especially again in supination, they had a 63% supination strength compared to 93% in patients that were treated with surgery. So quite a significant difference. There's a number of surgical techniques for repairing the distal biceps. And normally when you're talking about problems with multiple surgical techniques, that typically means there's not a great option. But in this case, these are all really good options. And this is a surgery that tends to do pretty well functionally once fixed. General conversation is 1 incision versus 2 incision. I know a lot of the guys in the sports division will do a single incision surgery. I prefer a 2 incision, but again, both of these approaches work quite well. They do have different risks. So single incision technique has a higher risk of a nerve injury, whereas a 2 incision technique typically has a higher risk of heterotopic ossification. For me, when I do a 2 incision technique, I always treat these patients with indomethacin afterwards. So just to touch briefly on the outcomes, overall the outcomes are quite good. This is a large study that was done, no significant difference in range of motion or strength between a single incision or 2 incision approach. This study shows that there was significantly lower complication rate after a 2 incision approach, but there's other studies that have found the opposite of that. So again, generally speaking, similar results and similar complication profile. The rate of re-rupture is actually quite low. As I said before, it's less than 2%. This is a large study here done out of the Mayo Clinic that showed the rate of re-rupture was about 1.5%. And of course, all of these were blamed on patient compliance as opposed to any surgical error or technique issue. Moving on to the triceps. So just briefly, the triceps anatomy, there's 3 heads of the triceps, the long head, the lateral head, and the medial head. This inserts onto the olecranon. It has a wide footprint distally with a width of between 2 and 4 centimeters. This is a rare injury. It accounts for less than 1% of all tendon ruptures. Typical age is 30 to 50. Males, much more common than females. Again, I have not come across a female with a triceps rupture in the past. Typically related to sports, I see a lot of triceps ruptures with patients that were weightlifting, but also football players. Risk factors, obviously, anabolic steroid use. Mechanism for this injury is traumatic event of overloading the extended elbow. This can typically be diagnosed clinically. Patients will come in with large ecchymosis over their elbow. You can get an x-ray on these patients, and I often do. Sometimes you'll see a little fleck of bone off the tip of the olecranon. And then just like distal biceps ruptures, I typically get an MRI. Again, it helps evaluate partial tears, the extent of partial tearing, but it can, again, evaluate the level of the tear and the degree of retraction for surgical planning. Management, really surgical management is the best option for most patients. Low demand patients in poor health can be candidates for non-surgical intervention. All others are operated on. Outcomes are quite good. The re-rupture rate is rare, high patient satisfaction, and then up to 80% return to sport after distal triceps repair. At this point, unfortunately, I will not be able to answer questions live, but here's my email, so feel free. Don't hesitate to reach out to me, shoot me an email if you have any questions about this talk. I appreciate the opportunity.